Good morning everyone. Today we are going to discuss about the pediatrics question that were asked in the recently concluded NEET PG 2023 session. I am Dr. Sarath Balaji on behalf of PW. The questions were mainly based on the memories recollected by the students who had given the examination. There might be some minor discrepancies. If you have any, kindly post in our channel so that we can come up with a corrected version 2.0. Let us go to the question. The first question. The best sign of adequate growth in an infant who is born term with a birth weight of 2.8 kgs, weight gain of 300 gram per month up to 1 year. Let us see, is it true or false? We all know that an infant should gain a minimum of 330 gram per day in the first 3 months. 30 gram per day in the first 3 months. And it should be followed by, so it roughly comes around 900 grams per month. It roughly comes around 900 gram per month in the first 3 months. Later on it is 400 gram per month. Roughly 400 gram per month. But here it was given weight gain of 300 gram per month up to 1 year. So this is definitely false because it is 1 kilogram, 900 gram to 1 kilogram in the first 3 months. Increase in the length of 25 centimeter in the first year. Let us see whether it is correct or wrong. We all know that at birth, what is the height at birth? So at birth, a newborn is around 50 centimeter and about 1 year it is 75 centimeter, and at 2 years it is 90 centimeter, and at 4 years roughly a child is 100 centimeter, and from 4 to 12 years roughly it is 4 to 6 centimeter per year. And it is often said that between 4 to 12 years, if it is less than 4 centimeter per year, you need to rule out either growth hormone or thyroid deficiency. What is the question here? The question says that, so what is the increment of height in the first year from 50 to 75? So you have 25 centimeter in the first year. So is the first choice correct? Let us see. Correct increase in the length of 25 centimeter in the first year? Yes, it is correct. It is correct. Anterior fontanelle closure by 6 months. Is it so? The answer is not. Anterior fontanelle usually closes by, very good, 15 to 18 months. Anterior fontanelle usually closes by 15 to 18 months. Here it closes by 6 months. What does it mean? Premature closure of anterior fontanelle may be a sign of microcephaly. But if it is so, then it is not a normal baby. So this choice is also wrong. What is the fourth choice? Weight under 75th centile and length under 25th centile. Is it so? Weight under 75th centile and length under 25th centile. Let us see. What are all the percentile curves you have? So if it is, whether it is a height or weight, the center one is 50th centile. Center one is 50th centile, and you have two curves below it. So let me say this is 25th and this is 3rd. And you have two curves above it. Let me say 75th centile and let me say 97th centile. So what does it mean? 50th centile is normal. And you have 3rd centile and 97th centile. What do you mean by 97th centile? Means plus 2 ST. 3rd centile means minus 2 ST. Minus 2 ST. Here the weight is less than 75th centile. So can it be normal? It can be normal. It can be normal, but they had not mentioned exactly under which centile it is. I can say 50th centile, I can say 25, whatever it may be. But since they say 75th centile, I can say I can take it as normal. And let me go to the next thing, length under 25th centile. So this is 25th centile. If length under 25th centile, can it be normal? Yes, it can be normal. And again, we don't know whether it is less than 2 standard deviation or less than 3rd centile. Even then, I can take it as normal. But look at this. The increment of weight is less than 75th centile and increment of height is less than 25th centile. So what does it mean? There is a discrepancy. There is a discrepancy in weight and height. So it cannot be a normal infant because there is a discrepancy in the increase in the weight and height. As a whole, after analyzing all these things, we can say a weight gain of 300 gram per month up to 1 year is false. Anterior fontanelle closes by 6 months is false. The last one is also false. So we can go with the answer B for first pediatrics question. The second question. A preterm newborn is found to have respiratory distress at birth. Which of the following is the reason for this? Let us go to the small discussion. The preterm is having respiratory distress since birth. Okay, the preterm is having respiratory distress since birth. So this is here preterm. The child is having respiratory distress since birth. So the onset is less than 6 hours. What are all the two causes? The two causes, one is hyaline membrane disease, whereas the next one is hypothermia. The most common cause is hyaline membrane disease because your surfactant usually seen in lung homogenates by about 20 weeks. It is seen in amniotic fluid by about 28 to 32 weeks. And maturity is usually attained by 35 weeks and above. Since this is a preterm, there is a quantitative defect of surfactant. Leading to respiratory distress. Probably this is a case of hyaline membrane disease. What is the role of a surfactant? The role of the surfactant is to reduce surface tension. When at the end of expiration, so that alveoli do not collapse at the end of expiration. So it increases the compliance of lung. What happens in hyaline membrane disease? In hyaline membrane disease that occurs in a preterm, what happens here? The surfactant is less. So what happens? The surfactant is less. So what happens? The surface tension is more and the lung become less compliant. So what must be the answer? Let us see. Increased compliance means the child can withstand, so it will not develop any respiratory distress. Is it due to increased surface tension? Yes, surface tension is increased because of the absence of surfactant, but compliance is decreased. Decreased compliance, the answer is yes, but at the cost of increase in surface tension because of the absence of surfactant. Is it due to decreased compliance? Yes. Due to what? Increase in surface tension. Due to what? Because of the deficiency of surfactant protein. So what must be the answer? The answer must be C for the second pediatrics question. What is the third one? Is it increase in compliance? No, it is again decrease in compliance due to increase in surface tension. So the answer, it is a easy question. So the answer is C for the second pediatric question. Third one, a 3-month-old baby was brought with jaundice and clay colored stool. Jaundice and clay colored stools. What does clay colored stool indicates? Clay colored stool indicates. So what does it indicate? The first clue is clay colored stools. Clay colored stools is the first clue. Clay colored stool means what? Absence of bile pigments. Bile pigments in the intestine. Where does it happens? It happens in a obstructive jaundice. It happens in obstructive jaundice. What are all the two common causes for obstructive jaundice? The two common causes are, one is extrahepatic biliary atresia. The second one is choledochal cyst. Choledochal cyst. In obstructive jaundice, what happens? Conjugated bilirubin will be increased. Conjugated bilirubin is increased. Here, conjugated bilirubin is increased. But what is the histology along with that? Periductal proliferation. Where do you get this periductal proliferation and fibrosis? Is it Crigler-Najjar syndrome? You all know that the inherited hyperbilirubinemias. So what are all those inherited hyperbilirubinemias? It can be divided into two. One is conjugated, another one is unconjugated. Unconjugated, usually you have Crigler-Najjar and then Gilbert. But here the question it was said that it is conjugated bilirubin. So that you need to know whether it is Dubin-Johnson or Rota. What happens in Dubin-Johnson syndrome? In Dubin-Johnson, your liver histology will show black pigments. But here no such thing was given in the history. Second one is in Rota syndrome, the liver biopsy is normal, but here there is periductal proliferation. So when we consider conjugated hyperbilirubinemia, we can consider Dubin-Johnson syndrome and Rota syndrome as a differential diagnosis, but we cannot consider Crigler-Najjar. Why? Because it is unconjugated bilirubin. But in Dubin-Johnson you have black granules. In Rota it is normal. We are left with what? Extrahepatic biliary atresia. In that you will all know that it is characterized by periductal proliferation and fibrosis. If it is a case of neonatal hepatitis, which can also sometimes leads to this clay colored stools, but there in histology you will have giant cells. So we are ruling out Crigler-Najjar because it is unconjugated hyperbilirubinemia. We are ruling out Dubin-Johnson and Rota because of the absence of this characteristic periductal proliferation and fibrosis. Finally, we are concluding biliary atresia as our answer. Again, this is also an easy question. Fourth question. A 10-year-old boy presented with periportal retroperitoneal hematoma. Okay, hematoma. There have been multiple episodes of joint swelling and joint pain in the past. There is no mucosal bleed. Which coagulation factor deficiency is responsible? Clinically, is it possible to differentiate whether it is a von Willebrand or platelet or any other thing? The answer is yes, you can differentiate. How? When you have predominant mucosal bleed, you are dealing with a case of von Willebrand deficiency. When you have petechiae and purpura, you are dealing with platelet disorder. When you have deep muscle and joint bleed, it is usually due to clotting factor deficiency. The usual clotting factor deficiencies are factor 8 Factor 9. Factor 8 we call it as hemophilia A. Factor B we will call it as hemophilia B. And hemophilia C is factor 11. Factor 12 deficiency is not associated with bleeding. Not associated with bleeding. In all these cases, what happens? Your PT will be normal, whereas your APTT will be high. APTT will be high. What is the question here? The question here is no history of mucus bleed. Predominant mucus bleed occurs in von Willebrand deficiency, and also mucocutaneous bleed will occur in platelet deficiency. Since there are no mucosal bleeds as well as there are no cutaneous bleeds, reasonably I can rule out von Willebrand and platelet deficiency. Since there is joint muscle and joint pain what it is called as target joint. Predominantly it must be a case of factor 8 or 9 deficiency, whether it can be a case of hemophilia A or hemophilia B. Can it be von Willebrand deficiency? Again it cannot, because it is characterized by mucus bleeding, but here there is no mucus bleeding. Can it be factor 11 and 12 deficiency? It can be factor 11 deficiency, but it cannot be factor 12 deficiency because it is not associated with clinical bleeding. What about this lupus anticoagulant? They often present with thrombosis, arterial or venous thrombosis rather than bleeding. Again, it cannot be a choice. So concluding, we can say the answer for 4 is factor 8 and 9 deficiency with respect to this deep muscle and joint bleed. So the answer is A. Then next, a child presents with the deformity. He has a crossed gait and walks with the toe in front with support of a clutch. Which of the following deficiency would lead to this picture? You all know what is this. This is tibia vera, or otherwise I can say bowlegs. It is a easy question. You can say it is due to vitamin D deficiency. Let us go to the choice. Vitamin D deficiency, the answer is yes, it is a case of vitamin D deficiency. Vitamin C deficiency usually presents with subperiosteal bleed, or else I can say because of that subperiosteal bleed you can have pseudo-paralysis, but no frank joint involved. Whereas vitamin A deficiency usually leads to corneal and conjunctival involvement. Vitamin A. What will happen to vitamin E deficiency? Vitamin E deficiency is characterized by hemolysis in preterm. In preterm, vitamin E deficiency. One more thing is ataxia can occur in vitamin E deficiency in older children. The question here is bony deformity more fits into vitamin D deficiency. Here. The answer is easy. Sixth, a 12-year-old child with tachypnea and severe dehydration, random blood sugar of 550 with a urine glucose of 2 plus or 3 plus, bicarb of less than 7.1, pH of less than 7.1, bicarb of less than 7 millimole per liter. What is the most appropriate management according to ISPAD? Okay, International Society for Pediatric and Adolescent Diabetes mellitus. The question directly says that the child is suffering from DKA. The child is suffering from diabetic ketoacidosis. So what is the clinical definition for diabetic ketoacidosis? Your sugar will be more than 200 milligram per deciliter. Your pH should be less than 7.35. Your bicarbonate should be less than 18 millimole per liter, and your ketones, blood ketones, beta hydroxybutyrate in particular, should be more than 3 millimole per liter. This is the definition for DKA. Here blood sugar is 550, fits into it. pH of 7.1 fits into it. Bicarbonate 7 fits into it. So the child is suffering from DKA. But the question is, we all know that only at the end of first hour after dehydration correction, we will go for insulin. Invariably, we will start with 0.1 international unit per kg per hour. Only if blood sugar doesn't subside with this, we will go to 0.2 international units per kg per hour. But here the child had presented just now. So that definitely 0.1 international units per kg per hour is the correct answer. But the question is whether I can put normal saline 10 ml per kg, or should I go for normal saline 20 ml per kg to start with, bolus, to correct the shock. Whether we see whether the child is having shock or not. The child is having tachypnea. Tachypnea is due to what? Tachypnea is due to Kussmaul breathing, acidotic Kussmaul breathing. Tachypnea is due to Kussmaul breathing, and you all know that this acidotic breathing can occur when the bicarbonate is less than 10 millimole per liter. The child is having severe dehydration. But they had not mentioned whether the child is in shock or not. So what can I say? Whenever any child had come with DKA, I will see whether all will be dehydrated. So correction is the rule, whether shock is present or shock is absent. When shock is present, I need to go for 20 ml per kg, either normal saline or Lingerlac. When there is no shock, then I need to put 10 ml per kg of normal saline or RL. But the choice given here is 10 ml per kg one choice, 20 ml per kg one choice. In some books it was said that in the presence of shock you can go up to 10 to 20 ml per kg. Since the word shock is not mentioned, I preferably go for the first choice. If shock was given, if BP was given, if heart rate was given, then I will, based on the findings of tachycardia, hypotension, capillary refill time, I will choose 20 ml per kg. Since there were no findings given here which is suggestive of shock, personally we would go for normal saline 10 ml per kg followed by insulin 0.1 international units per kg per hour. So the answer is A. Even though some may argue, but again there were no features given here which is suggestive of shock. What are all the features suggestive of shock? Increased capillary refill time, hypotension, tachycardia were all not given here. If they had given, then we would have chosen your 20 ml per kg. Here tachypnea is due to Kussmaul breathing. Severe dehydration is the rule in all cases of DKA. I repeat, the choice is 1 compared to 2. 7th question. A 2-month-old infant brought with swelling over the scalp since birth. What is the diagnosis? There is a great confusion here, and let us solve one by one. Is it a case of caput? Caput usually present at birth. Yes, it is present at birth, but usually resolves at 1 week. What about encephalocele? Encephalocele is usually frontal or occipital. It can be but position not in favor. Position not in favor. Here, where is the position? Look here. Here, where is the position? The position is over the parietal bone. The position is over the parietal bone. So, it is less likely to be encephalocele. As I told you already, encephalocele can be a frontal or occipital encephalocele. Least likely to involve this swelling over the parietal region. Is it a cephalohematoma? The answer is yes. The answer is yes. Why? Because it is persistent for more than 2 months. Usually cephalohematoma resolves anywhere between 2 weeks to 3 months. 2 weeks to 3 months. And it starts calcifying by about 2 weeks. So can it be cephalohematoma? Yeah, it can be cephalohematoma. Why? Because it is a 2-month-old infant. By this time, your caput would have regressed. Encephalocele, not a favorable position to diagnose. But what is the question? Many can argue whether it can present since birth. The literature survey reveals that it can present many hours after birth. Many hours after birth. We don't know whether it is 1 or 2 or 3 or 4 or no one knows. Since they had mentioned many hours after birth, even though it goes against since birth, we can go in favor of cephalohematoma. Why? The position matters. The position matters. It is over the parietal bone. The most common bone to undergo fracture is parietal bone, and this swelling exactly fits over the place where parietal bone is present. Even though you can argue against the presence of cephalohematoma since birth, the only swelling that can present over that parietal region and only swelling which can present for about 2 months will be cephalohematoma only, nothing else. Among all these options, cephalohematoma would be the diagnosis. Can it be a subgaleal hemorrhage? In subgaleal hemorrhage, the child will be in shock. The child will be very sick. And again, even if it is in the stage of shock or even if it is sick, it usually resolves by 2 to 3 weeks. Which one? Subgaleal hemorrhage. Here the question says that the child is around 2 months old. Again, less likely to be a case of subgaleal hemorrhage. Considering all these facts, a reasonable option could be cephalohematoma, even though it is present not since birth. It occurs many hours after birth. Answer must be, compared to all other options, answer must be C. 8th question. A child was brought with fever and stridor. X-ray next showed this picture. The probable diagnosis is, invariably all of you will answer, what is this called as? What is this called as? Yes, all you know. This is called a steeple sign. This is called a steeple sign due to subglottic narrowing. Due to subglottic narrowing. Occurs, what you know, ALTB or laryngotracheobronchitis, commonly caused by, not exclusively caused by, commonly caused by para-influenza. Even in times of COVID, we have seen many cases of group acute laryngotracheobronchitis as a presenting manifestation of COVID. But as a undergraduate, you need to know the most common cause is para-influenza and a fever low grade. Here they did not mention whether it is high grade or low grade. Fever is low grade and the sign is suggestive of acute laryngotracheobronchitis. But remember, this steeple sign is neither sensitive. What does it mean? It can be normal even in severe cases. Not specific. What does it mean? It can present in other conditions also. Now, it doesn't mean that steeple sign is suggestive of acute laryngotracheobronchitis, and absence of steeple sign doesn't argue against acute laryngotracheobronchitis. But as far as an undergraduate is concerned, you can say for your level. Steeple sign is more in favor of a acute laryngotracheobronchitis. Can it be epiglottitis? Epiglottitis is characterized by thumb sign, an enlarged epiglottis that can be seen in the lateral X-ray neck. Foreign body aspiration usually without fever and sudden in onset. Here they had given fever. If it is a low grade fever, more in favor of a ALTB. If it is a high grade fever, more in case of a epiglottitis. And low grade fever to start with, then become high grade fever. Think in case of a bacterial tracheitis secondary to your parainfluenza. If it is a case of laryngomalacia, it would have been present since birth. So excluding all, our diagnosis will be acute laryngotracheobronchitis. Ninth question. 3 weeks old baby pneumonia presentation. I'm sorry, I don't have a proper framed questions here. The only option available to me was azithromycin along with no other option. But the essence let me discuss. Whenever you have a child with pneumonia, that too 3 weeks old, I can say whether it is febrile or afebrile. Febrile or afebrile. Afebrile is usually due to what you call it as atypical pneumonia. Atypical pneumonia. Or otherwise I can say afebrile pneumonia of infancy. Or I can say afebrile pneumonia of infancy, which is usually caused by chlamydia. And the drug of choice is azithromycin for 3 days. 20 mg per kilogram azithromycin for 3 days. It usually presents with Krebs, no coryza, no wheeze. That is how you will differentiate from bronchiolitis. No coryza, no wheeze. Febrile toxic means you need to think in terms of a bacteria. So if it is febrile and toxic, think in terms of gram-negative organisms or strep pneumoniae. If it is afebrile and cough is the predominant complaint without any coryza, without any wheeze, think in terms of a chlamydia pneumonia. For that, the drug of choice is azithromycin. If it is associated with URI, if it is associated with wheeze and less toxic, it can be due to RSV bronchiolitis. Or if the presentation is predominantly cough, if it has paroxysmal along with the post-tussive vomiting or whoop, which can be seen in this age group because they are partially immunized, then you can say pertussis. Again, the drug of choice is azithromycin. Azithromycin is given to prevent the transmission. It may or may not reduce the intensity of cough. Considering all these facts, whether it can be a pertussis or afebrile pneumonia, we can choose macrolide as the drug of choice. If you have some other thing that you want to add in this question, you can add along with the choices. We can come up with a corrected version soon. 10. Chloride test, sweat test is done for very easy cystic fibrosis. Sweat chloride test, it can be done after 3 days. People usually say more than 60 millimole per liter is considered as positive. More than 60 millimole per liter. But in infants with positive newborn screening test, Newborn screening test. What is the newborn screening test? IRT. What is IRT? Immunoreactive trypsinogen. Immunoreactive trypsinogen. Trypsinogen. That is IRT. When IRT is positive, even a value of 30 to 59 can be considered positive. Can be considered positive. Remind again one more thing, you need to do 2 times at 4 weeks apart, whatever it may be, to say positive sweat chloride test. Positive sweat chloride test. What is this? 11th question. A 6-year-old boy brought with complaints of muscular pain involving cough, fatigue and inability to do exercise. What is the probable diagnosis? My dear students, whenever you have exercise induced muscle cramps, it can occur in 2 conditions. One is Gentleman syndrome, which is due to magnesium deficiency, which can present with tetany. Whereas another is McArdle's disease. This McArdle's disease is due to muscle phosphorylase deficiency. So that what happens, your glycogen, muscle glycogen cannot be converted into ATP. As a result of which you will get muscle cramps. Sometimes it can lead to rhabdomyolysis. This can lead to acute tubular necrosis. Since the question is limited ability to do exercise, more in favor of a McArdle's disease. Gaucher's disease, you all know that. Gaucher 1, 2, 3. 1, 2, 3. All are characterized by hepatosplenomegaly. And Gaucher 1, no neurologic involvement. Whereas 2, fast neuroregression. 3, slow neuroregression. But in this question, I have not seen any neuroregression or hepatosplenomegaly, so this is not a correct choice. Can it be pompous? Pompous usually presents with massive cardiomegaly, pompous along with the floppy infant. Again, the manifestation will be very early. Here, the child is 6-year-old boy, less likely to be pompous. Again, many can argue whether it is a case of Duchenne muscular dystrophy. In Duchenne muscular dystrophy, what happens? Delayed milestones. Tiptoe walking. Frequent falls. Inability to get up. So what happens? Even the child cannot get up from the sitting position. Very, very difficult. So there is proximal muscle weakness, which usually manifests as oversight, waddling gait, lumbar lordosis. Even these basic things cannot be done by the child. Then why do you think about that exercise induced muscle cramps? Less likely. Even these basic things are affected in this child, then we can think in terms of Duchenne muscular dystrophy. Here, these simple things can be done by the child, and only when the complaint is exercise induced intolerance. Analyzing all these, our diagnosis will be McArdle's disease. 12. A preterm with the respiratory distress is found to have ground glass opacity in the lungs on chest x-ray. What is deficient in this baby? This is little bit tricky because all of us know that this is a case of hyaline membrane disease. Because the child is having ground glass opacity, point number 1. The child is having ground glass opacity and it is a preterm. So the answer indirectly goes without saying that it is a case of hyaline membrane disease and it is due to surfactant deficiency. What does this surfactant contain? What does this surfactant contain? Dipalmitoyl choline. That is your lecithin. Lecithin. This is around 37%. 2. Phosphatidyl glycerol. Phosphatidyl glycerol. 10%. These two are surface reducing agent. These two are surface reducing agent. Surface reducing agent. Where are the other things? What are all the other things? You might know the other things are 1. Phosphatidyl inositol. Phosphatidyl inositol. And what other things? You have neutral phosphorus. You have one is phosphatidyl inositol. Second you have neutral diacyl glycerol. You have cholesterol. No one knows whether they have any effect in reducing the surface active, in reducing the surface tension. Since also your sphingomyelin. Considering all these facts, sphingomyelin, yes, but we don't know. Dipalmitoyl ethanol amine, yes, it is there, but whether it reduces or not, we don't know. Phospholecithin, what is it? Phospholecithin. We have dipalmitoyl choline, DPPC, which is your lecithin. So the major surface reducing agents are, one is DPPC, that is your lecithin, that contributes to almost 37%. Second one is phosphatidyl glycerol. Excluding that, your A, B, C, D surfactant proteins, your phosphatidyl inositol, sphingomyelin, cholesterol, all are present in the surfactant, but whether it is reducing the surface tension, we really don't know. That's why the answer is lecithin, and they had not given phosphatidyl glycerol. Considering all these facts, the first choice will be the correct answer. With this, our pediatric sessions are over. If you have any doubt or any queries or any discrepancies, kindly post in our channel. Thank you.